The first human-to-human heart transplant was done in 1967. The first pediatric cardiac transplants were between 1981 and 1986. Our program here started around 1984. The first neonatal cardiac transplant was done in 1985. And of all the transplants done, like all organs, all time, about 10% of them are pediatric. And the heart transplants are one of the smallest organ sets that are done, or the smallest population. We have done since 1984 between 150 and 175 pediatric heart transplants. We perform on average 5 to 10 a year here. Last year we did 14, so last year was a busy year. Indications for heart transplant, you have children who have a progressive decrease in their cardiac function. You have kids who have congenital heart disease that's not amenable to any surgical repair or palliation. A lot of these kids have already had previous surgeries and their bodies can't tolerate another surgery. Their anatomy is such that even if they did do a repair, once that next repair was done, then they would no longer be a candidate for transplant. Another indication is growth failure, secondary to heart failure. And if they have refractory malignant dysrhythmias, so a lot of times if you can't get the heart rate under control, if you get them a new heart, then it sort of resets everything. And then if they have a need for continuous IV inotropic support, any type of circulatory support, like a ventricular assist device or ECMO, those would all be indications for transplant. Indications for retransplant or second transplant would be primary graft failure and advanced transplant vasculopathy. And that's the coronary artery disease that you get from a heart transplant. There have been third heart transplants done. Those are fairly rare. There's been around 30, I think, in the database that have been done. So it is possible. These are just some graphs from ISHLT, which is the International Society of Heart and Lung Transplant. This one was from 2012, and you can see diagnosis in pediatric heart transplant recipients for less than 1 year of age, the diagnosis. You can see that there's been a change in between the periods of 1988 and 1999. Most of the diseases were congenital, and now it looks, for less than 1 year of age, we're doing more myopathies than we did in the past. And these are for kids, the diagnoses in kids who've been transplanted between 1 and 10 years of age. And again, myopathies are increasing over the congenital heart disease. And in that age group, it's more because surgical palliation has been becoming more common and more successful. Now, in the later years, you see how it flips to being more myopathy than congenital heart disease, and that trend continues. One of the biggest questions that we face as a heart transplant team is when to list, because you don't want to list too soon and you don't want to list too late. So you don't want to insert a new heart when the native organ is still viable, because then you just start the time clock going once you transplant a new heart, because new hearts don't last forever. So you want to make sure that that timing is good. So some of the things that we think about and we look at is what the progressive deterioration of the ventricular function looks like. How much need do they have for the inotropic support like milrinone or dopamine? We look at pulmonary hypertension. If it's progressive, then you don't need to, but it's best to transplant at a time when the pulmonary hypertension is reactive. If it becomes fixed, then the new organ goes into the pulmonary system having to pump against this much higher pressure, which it's not used to doing. So then the same process happens. They can get a type of restrictive cardiomyopathy because it keeps trying to push against those pulmonary arteries and it can't get the blood out. And then everything just backs up and it gets big because it's trying to pump a lot, and then it becomes engorged, and you just get heart failure again. You also need to look at the type of arrhythmias, if they're responsive or unresponsive to medical management. You need to look at the level of growth failure, along with all the other symptoms and the signs that are going on in the patient, and then you need to look at the child's quality of life. The main reason to do a transplant is for quality of life. That's the goal, is to improve that. Dr. Crowley, when he used to head up the program, one of the topics that he talked about with the parents and with the kids during our pre-transplant evaluation was really important to me. He talks about how you never want to transplant somebody because you're afraid. You want to transplant them for good reason, for good information, and for the goal of quality of life, not because you're afraid somebody's going to die, which I think is pretty important to remember. Absolute contraindications to heart transplantation. If you guys could just sign in, that would be great. Absolute contraindications would be if there's a major central nervous system abnormality or a severe dysmorphism that will not get better after transplant. If they have irreversible lung, renal, or liver disease, and that's sort of a sticky one because you never know if the lung, renal, or liver disease is from the heart failure itself. So we do a lot of consulting with other disciplines to get their input. If there's an active malignancy, you do not want to transplant someone because once they're immunosuppressed, then that malignancy can become untreatable. If they have severe pulmonary disease with a non-reactive pulmonary vascular resistance, that goes back to the pulmonary hypertension that I referenced in the previous slide. Relative contraindications, which get sort of fuzzy, and they get fuzzier all the time. If you have diabetes, which is insulin dependent, if you have a storage or mitochondrial disease, with diabetes, that's going to get worse with the transplant because of the amount of steroids and the amount of Tacro that the kids are on in the very beginning. A lot of our kids will be on insulin post-transplant, not permanently, but for a while, and I don't have a time frame as to when the a while stops, but it's generally around the time, give or take a few months, of when the steroid is discontinued. If they have an active infection, if it's viral or bacterial, fungal, any type of infection, that is a relative contraindication to transplant because, again, you're going to be suppressing the immune system a lot, and you don't want that infection to become a fulminant infection. If they have a history of non-adherence, that is a relative contraindication to retransplant, and we can talk about our friend later, which I think is a really important topic to talk about. If for those of you who don't know, you might as well talk about it now.
No name, no name.
No, I know. For those of you who don't know, we have a patient, an 18-year-old patient in the PCTU right now who did not take medications for months, had several interventions as to try and change that, and behavior did not change. And of course, the ramifications of that is that that person is now in the PCTU, had been on ECMO, had horrible functions. Now the function is coming back, mentation is coming back, but the lungs are terrible and there's a lot of issues going on. So what research has shown about noncompliance is adolescence, as we all know, is a very difficult time, and so you have to take that non-adherence in adolescence and then a desire to change behavior and then a contract and all of that. So her plan will change as she gets farther and farther out from this particular incident, but it also depends on the child or the adolescent And there's an adage that I talk about, meaning that I will not work harder than the patient, especially when it comes to transplant and being compliant and things like that. There's a responsibility that the person, the patient, the organ recipient has to themselves and to the donor and their family. So we take that very seriously. So as that person gets farther and farther out from transplant, or further out from this particular incident, you may find that that plan changes, but it's a very thoughtful plan. If someone, though, is non-adherent and it's long-standing, and they, of course, get sick like this and have this sort of colloquial is the come to Jesus, like they are like, oh my God, I never should have done that. Then there needs to be a pattern and established behavior before we will make any decision if we can move forward with retransplant or not.
So this girl, we haven't decided yet whether to relist her or not?
Correct. Correct. If we can save like those more in-depth conversations to the end if we have time, because I think that those are really important to talk about, especially with nursing staff who doesn't, you don't always get to hear what types of discussions go on, and I don't always have the time to talk with you, so I'd really like to talk about that in this type of a forum, because I think it's super important. Super. Then another contraindication, which we are getting better and better at counteracting, is an elevated panel reactive antibody. And those, a PRA, are the common antigens seen in a donor population. So that's that PRA, that red top tube that we ask you to test for, the one that is always confusing. That's what that one is.
That one.
Yeah. During the evaluation, it's fairly extensive. There's a history and physical. We do an EKG, we do a chest x-ray, we do an echo, and then we'll do a biopsy of the heart muscle if that's indicated, to look for any type of like myocardial disease, if there's any type of myopathy, things like that. We'll do a 6-minute walk or an exercise test if that's indicated. They typically get a catheterization. And these are like the common tests that we do. We do a lot of blood testing. We do tissue typing, which is HLA, which is our, it's a type of antibodies that are very specific to us as individuals. It's more specific than DNA. It's a type of blood group antibody, and we look at both class 1 and class 2 antigens. I'm not going to go into a lot of detail on what these are, but they're very specific immune markers to us that are very important when we're looking for donor organs, because if we don't have a good match, then you increase your risk of rejection. And then the PRA, so the tissue typing is what, like if I was going for a transplant, tissue typing is what my markers are. My PRA is what I react to. Does that make sense? Okay. And then, of course, we look at blood typing. We do an infectious disease workup, which includes a complete antibody titer for herpes, CMV, Epstein-Barr virus, HIV, the hepatitis panels. We check for varicella, toxoplasmosis, and we also do an immunization evaluation. We have social work involved. We have a financial evaluation involved. The reason we do a financial evaluation is to make sure that the family has enough resources to be able to handle this without going bankrupt. We won't not transplant someone if they don't have insurance or money or the financial wherewithal. We will help them get it. We also do utilize subspecialty consultations as indicated with neurology, nephrology, psychology, pulmonology, hepatology. Anything we need to look at, we will. And there's a girl on 11 right now who's had an extensive pre-transplant workup. And the reason being is that we need to know that the disease process that she has going on will not come back. and also if she needs heart or heart-lung. So her evaluation's been really extensive. When we list someone, we list them with UNOS, which is the United Network of Organ Sharing. And UNOS is the governing body, it's a national governing body for equal allocation of donor organs. And so they are the organization that maintains all the lists and gets all the donor information and then matches people. There are donor shortage issues. If you, if you look at the graphs where you have the number of people waiting for transplant and the number of people donating organs, the donating organ level is flat, basically from like the mid-80s, early 90s. The number of donors continues to stay at a flat level, but the number of people waiting for organs has gone up. So that's why you see so much push for organ donation, sign up now, things like that. Because in this country, it's voluntary.
Is it not voluntary in other countries?
Yeah.
Really?
Yeah. And I can't tell you which ones, but I do know that in some countries it's not voluntary. But ours is, and so that's debate on if you either donate. Well, that's a whole nother debate. So I'm not going to.
Is there an age limit to donate though?
Is it what?
Is there an age limit to donate?
No.
I know with bone marrow there is.
No. I
Like,
mean, we
to be
take
too old?
infant
Yeah,
transplants.
Too young.
Well, it depends with heart because you do not, that's a good question. For pediatrics, there are age limits, and they're not hard and fast age limits, but we would prefer not to transplant someone who's young with a donor organ that's over 25 years old. And that's because of the coronary arteries, and that they have a tendency to be older. I mean, they are older, they don't have a tendency, they are older, and they will fail sooner. So to protect the recipient as much as possible, there is an age limit that we are required to put in our listing information. Listing criteria, we need to match blood type. This is becoming fuzzy as everything becomes fuzzy over time. We do ABO mismatch for infants, anywhere from 0 to 1 years old. And this is the requirement. You could do it up to 2 years. We don't do it up to 2 years unless we think it's a possibility that the candidate is not making antibody, and so we'll test that, and that's when it gets confusing because we want to do anti-A and anti-B titers. And depending on what the ratio is that the person is making, will we be able to accept an ABO incompatible heart. So if you have someone who's blood type A, you can potentially have that person transplanted with someone who is a blood type B. And then there's a specific protocol to follow for that. There have been cases of ABO mismatch in adult transplants. We have not done them here, but they have been done successfully at other centers. We also need to include a very specific weight criteria. The whole point of the weight is because of the size. If you have a baby who's like 8 kilos, a child who's 8 kilos, and they have a cardiomyopathy, their heart is going to be pretty big. So they have a lot of space inside their chest wall in their chest cavity to be able to take a big heart. So we could take an organ from someone who's 8 kilos to 16 kilos. So we usually go up to double their weight. And then we have to change that over time, the longer they're out waiting. Most people are listed with a virtual cross-match, so that means we look at the HLA typing of the recipient and the PRA of the or the HLA of the donor, and we see if they match or not. And that's where that PRA comes into play. And if everything on paper looks like it matches up and there's not gonna be an increased risk of rejection, and everything else looks good, then we'll take that organ. Virtual cross-match is when you do that paper-to-paper. Prospective cross-match is when we need to limit the prospective donors to the state of Michigan, because we need to check blood to blood. We need to check the recipient's blood against the donor's blood. And if it clumps, then we don't take that, because that would mean that they would have rejection right away and they could die. When you check blood to blood, that's called prospective cross-match, and it's prospective in limiting the donor pool because we're that worried about the recipient rejecting right away, and it takes time. So you have to limit it to the state of Michigan. Factors affecting weight
How do you get the
intensity.
blood together? Like, what if they're on the
Well,
outside?
you have to take,
Somebody has to go there and get blood and bring it back here and then you test it?
And you only go to that prospective cross-match if your original, like, paper-to-paper shows concern?
No.
Or everyone does a prospective cross-match?
No, not everyone does a prospective cross-match.
So
The
how do you
people
get
that
to
were
that
really
point?
worried, depending on what the level of their PRA is.
Okay.
So if you have someone who has a PRA of 0, then that means you can accept any heart and you technically should be fine.
Okay.
If you have a PRA of like 85%, that means that you will react to 85% of the population.
Okay.
So you're limited to that 15%.
So you already know that, like, early on, that they're gonna need that prospective cross-match?
Yeah.
Okay.
And so UNOS has, the Gift of Life, that's like a local organ procurement organization. They have blood, I'm sorry, I'm having background. Can we bleep this out too?